to Brain Talks. I'm Deborah Kan, founder of Being Patient. Today we're going to talk about technology, in particular artificial intelligence, and how it's intersecting with treatment and diagnosis of diseases like Alzheimer's. Well, I'm happy to introduce us to Dr. John Walker. He's from a company called U Method Health, which has developed artificial intelligence, and in particular in the treatment of Alzheimer's disease. Welcome, Dr. Walker.
Good morning. Thank you.
So tell us a little bit about, take us down to the very basics. What is artificial intelligence doing today in terms of either diagnosis or treatment of a disease like Alzheimer's?
Can I do a little bit of an introduction there, because it's a big field, and I looked at all your other videos and none of them went into the depth that we may go into this morning. So I think a little introduction is good.
Okay, go for it.
If you're an expert cook or you're good at cooking, you go, okay, well, that's nice. It turns out there's many areas of expertise there. So for example, you may know everything about baking bread. You know, here's yeast and temperatures and how long things need to set. Or if you make sauces or roux, you know, here's how to mix the flour and the eggs and the oil and so on. So saying that someone's an expert cook actually implies a lot of expertise in different areas. So far, so good?
Yeah, so far, so good.
All right. So artificial intelligence similarly has a whole lot of techniques in its arsenal as well. It's a long list. They're all pretty technical. Let me do 3 of them. And, if I go off the track here, let me know.
Okay.
Okay. So there's a whole family of things in artificial intelligence called rules-based systems. And it says, you understand the rule for how something should work. So for example, if your vitamin D level is low, there's probably a rule that says, okay, you need to take, a vitamin D supplement to raise it. Mm-hmm. Okay. So that would be like the first rule. But there's another rule that says, well, yeah, but if you take too much of it, it's toxic. And so there's a rule that kind of overrides the first rule. And then there's another set of rules that says if you're taking some other drug or medication, it might heighten or amplify the effect of that medication. So now you need to change the dosage. And so you end up with these stacks of rules. So far, so good.
Right.
And what you have to do is weigh them and prioritize them and say, in which situations is this most important and which situations is the other most important. So we've had to do that, in terms of artificial intelligence for essentially the entire wide field of medicine, genetics and medications and different diseases and allergies and so on. So step 1 for AI. Let me do a different field in AI called machine learning. And you may have seen lots of examples of that in the press. Let me do an example here. If your HDL blood level, I think everyone knows what that is. That's the good cholesterol. If your level is 25, you'd like to have it raised to 50. And so the question is, if I kind of come back and measure you in 3 months, and your HDL has gone up 5 points. If that's the best that you can do, if that's the expectation of what a normal population, someone who works hard, really tries hard to raise their HDL, if they can raise it 5 points in 3 months, and everyone knows that's a success. But if the expectation is, well, we need you to get from 25 to 50, 3 months have passed, you've only done 5 points, then everyone feels like a failure. So there's a kind of a coaching aspect to this. And the machine learning is, what are the expectations? What can people expect? As we look at data, there's no good answer in the medical books that says, here's what someone's HDL looks like, because it depends on their age and their gender and a whole lot of things like that.
So let me just back up a little bit. I know you want to.
Thank you.
But how much, when we talk about artificial intelligence, essentially what we're telling we're telling a machine a certain amount of information that they can compare with other data points to come up with certain formulas, right? And so when we're talking about our own health, I think to start from the beginning, how much do we actually have to tell a machine before it can start drawing conclusions? So you bring up cholesterol, your HDLs,
Sure.
as an example. So
Yes.
how much would, in that example, it require for someone like me to give, daily readings, weekly, and who is it comparing it to?
I don't mean to give you a flippant answer, but let me start with, again, I work at a commercial company. We designed this software to start with essentially nothing. So if you told me only your age and gender, and we're talking about Alzheimer's, we actually know a lot of information that says, okay, we know if you're at this point, here's the next test to ask for, here's the next thing to get measured. And yet everything added on top of that fills out the picture more completely. So if you give me blood numbers, then I know a lot about your blood chemistry, and I can say, okay, interesting, your cholesterol's in good shape, but we're seeing, a problem with kidney disease. If I get genetic information, then I know a lot about propensities, what's pushing you, what's the right drugs to be matched to, and so on. And so every one of these adds to the picture. So I know it's not as, what's the bottom line for how much information we should have? Again, when I say age and gender, that seems a little rude. And so you don't get very specific information. If you just give me your age and gender and say you're concerned about Alzheimer's disease, I'll tell you the basics. It says you need to sleep better, you need to exercise well, you need to improve your diet. But I don't know anything about your diet. So if you tell me more about your diet, then I can improve the recommendations from there.
So what is it today? I mean, let's start at kind of the end result and work backwards. So
All right.
What is it today that artificial intelligence can tell us? Can it make a diagnosis, or could it tell us what an appropriate treatment is in order to delay the onset of Alzheimer's and actually lead a healthier brain life?
That's exactly the right thing to do. That says it can predict and can give you the recommendations for what to do now and what to do next month and next, over the coming year to slow a progression, if that's the case, to prevent it, to actually improve your cognitive situation under a whole wide range of conditions.
So how many conditions?
And I didn't answer your good question. Okay. And what does that look like? It looks like a report to your doctor.
Right. So this is along the lines of precision medicine, but the machine is doing a lot of work for us. Is that right?
In fact, the machine's doing all the work. I'm going to ramble just for one more minute because you're very patient with me, because a third aspect of artificial intelligence is something called natural language generation. So it's another thing in that toolkit. It's like baking bread for cooking. And so we use that technique to have the machine essentially write reports where the doctor knows what every word means.
Right.
And also with that same information, we can write a report that goes to the patient or their caregiver. It's the same information, but it's in totally different language. It doesn't say QD for medications or PO. It's all written so that someone without a medical background can read the same thing. And it's all entirely done there. There's no human hands involved there.
So there's a lot of debate. I mean, I know that we can identify certain deficiencies. We can factor in lifestyle factors like how much exercise one person is getting. We could identify risk factors, A1C, sugar levels of an individual, and those can help us build a profile in accordance to living a better life for our brains, right? So we're talking about brain health here. So how many factors have you entered? How many, like both NLP and AI, how many factors are being entered into the equation to determine a precision medicine approach to treatment?
Let me answer your question, and then I'll also work on a different one with you. All right. So the answer is there's no simple answer, but we'll take an entire 23andMe genome file, and that's a spreadsheet with 700,000 rows. And we're not just looking at the 2 rows for APOE. We're looking at, your propensity for diet and for exercise. We're looking at other diseases you may have. We're looking at how you react to medications and so on. So the first 700,000 is the easy ones. And then we ask about, your medications, your family history. You had meningitis when you were 6. What allergies have you had? And it kind of the list continues to unfold. Often it's too many questions to start with at one time. So you kind of get the edge and go, what's the follow-up on these? Let me pick an example. Again, this is where I want to head to in my ramble.
Keep going.
Sleep apnea is incredibly important. And in fact, if you have sleep apnea, it trumps everything else. Anything
Really?
I can tell you about diet and exercise and lifestyle and whatever, you got to fix the sleep apnea because it's literally starving your brain.
How do we know that? Is that based on just past scientific research, or is that based on what you're seeing with artificial intelligence?
Extensive scientific research. So it's one of several things on my list here that we get to that trump everything else. It turns out there's a really simple way to understand if someone has sleep apnea or not. And I'm going to tell you, the formula is called STOP BANG, STOPBANG. And every one of those 8 things refers to, in a way, a question you ask to determine what someone's likelihood of having sleep apnea or going into that very soon. So the S stands for snoring. Do you snore? The N stands for neck circumference. You're looking up stop bang, I think, right now. You're right. But it's a simple world, but like a lot of things, it's a formula, and it's hard for your doctor to kind of run that formula in a 10-minute annual visit.
Right.
So will go ahead.
Sorry, go ahead.
No, you're good. Go ahead.
No, so I'm assuming there's different degrees of how severe people's sleep apnea is.
Yes.
So can machine determine that for us in terms of what we need to do to take steps? Or, what is the degree of precision?
Yes, it could determine that, but a better path, we believe, is we look at this, we look at the likelihood. Here the formula says it's highly likely, and it's just high, medium, or low. It's highly likely you have sleep apnea. And then the simple recommendation to their doctor is get involved in a sleep study. And that's where then everything gets quantified and the sleep apnea gets addressed.
So how does artificial intelligence help us in this example?
In this example, it's simply the rules-based system that says, here are the rules to determine someone's likelihood to have sleep apnea. And it comes as answers to some of these million data points that we've collected along the way.
So when you say 1 million data points, what exactly does that mean?
So we've got genetic information. We collect blood chemistry samples and the results of urine tests that you may have done. If you've done scans, we take that information about your allergies. Really important is the medications that you're on. What we've seen is people are on an average of 15 medications with a standard deviation of 12. That was a little bit of science there, but it says we regularly see people on 30, 40, 50, 60, 70 medications a day. And that's got extensive effects on cognitive health. And so there's an entire unwinding that has to occur there. Again, part of the artificial, part of the analysis that goes into the rules related to medications.
So we're getting a question in right now from one of our viewers saying, are you looking at the link that inflammation has in all of this? Because as we know, Alzheimer's disease, we could have the early hallmarks of the disease with plaques and tangles in our brain. And it's not until the inflammatory state do we actually see symptoms. So will AI help us to determine what role inflammation plays in all of this?
Let me answer. You asked, yes, that's a great question. And so let me answer with not quite a ramble, but I think I didn't answer well what we're looking at. So I have this little thing that says, other than genetics, what affects cognitive health? number one's inflammation. Okay, so we look at inflammation and a number of things in blood chemistry and history and so HSCRP and IL-6 and so on. But let me just continue. Inflammation, infection, insulin resistance and diabetes, stroke, heart disease, thyroid, kidney, and liver disease, HSV, HIV, depression, smoking history, midlife obesity, brain trauma, hormonal balance, homocysteine, metal balance, metal toxicity, mycotoxin exposure. So all of these are topics I think you have wonderfully on your website. And the answer is now how to bring them all together under one umbrella and say, all right, of everything we see, look, let's start by addressing inflammation.
So what is it, though, that inflammation is such a tricky thing, right? Because it presents itself in individuals. We don't really know how or why, but once it comes, we know it's there, right?
Yes.
And so,
yes.
So I guess what I keep coming at is like, what can machine do better than man in this whole thing?
It can identify and prioritize inflammation as the next thing to work on.
And it would do so by, how would it do so?
It would look at your blood chemistry. It would look at HSCRP, TNF alpha, IL-6. So those are the names of blood tests.
Anyway, you have to speak plain man's English.
Okay. It would look at different blood markers in your blood test panel that your doctor may not regularly ask for. And so we have a longer list of things to request. And the first one of those is this thing called high sensitivity CRP. And I've forgotten what CRP stands for. Protein. but if that's high, it makes sense to follow up with other inflammation tests. And then the recommendation at that point is then to work with a specialist in inflammation to go, all right, now let's identify exactly what's causing this. Is it related to allergy? Is it related to, internal disease and so on?
Okay, so
thing that the AI has done is gone through your genetics and looked at your propensity for a number of autosomal recessive diseases. So it looks and says, do you have the genetics for Crohn's disease, for example? And if you do that, hey, we've arrived at a driver. We've arrived at something we can address that in fact shows up as inflammation.
Okay, so at what point, we all care about, I'm fairly young. I don't have memory impairment yet. I'm worried that at one point I have a mom with Alzheimer's. So that makes me, even though I'm not E4, it does give me a genetic link to this disease. So at what point can AI help someone like me? Would I be a good candidate for this to assess what really my risk factor is in all of this? Or is it really for people who are experiencing memory loss to understand how they can better treat related conditions that could speed up the road to a disease like Alzheimer's?
The related conditions affect everyone. So it affects you without being APOE4. Me as well. So I'm not sure exactly your question in terms of when to start, but a simple answer is around age 55. There's extensive charts that says if you have APOE4, then some percentage of the population will start to see symptoms at age 60 to 65. And if you can get ahead of the train at age 55, you can push that curve further to the right. So
would this help people who already have a diagnosis? How could artificial intelligence help people who already have a diagnosis of MCI, mild cognitive impairment, or early stage of Alzheimer's disease?
Thank you. The answer is yes, because one of the first steps in this is unwrapping what their current status is. And so you may be diagnosed or measured, or you've taken standardized tests and see that you have MCI, but let's unwrap a lot of things before we get there. It may be driven by other things that can be undone. Let me give you an example. There's a class of medications, some drugs, that increase brain fog. So brain fog is real. It can be scored and it can be counted. So there are hundreds of medications that, and the term for this is ACB. It's called anticholinergic burden. And these are pretty common drugs, and you can readily look and see how much brain fog they're causing, and hence how much they're lowering your score, all of which is predictable on a standardized test. And so for each of those drugs, there are alternatives that are a good thing for your doctor to recommend, that says, all right, instead of taking this, take this because it has a lower score. And all of that's built into the system that says, knowing your medications, we can start from that point. And so, again, it's surprising how common this is.
So in other words, picking up where other medications could interfere with your cognition and in fact make your cognition worse. But and also
it's all measured, it's all well documented, and every drug is scored. There's a score of 3, 2, 1, or 0 for every drug.
So what about comorbidities, things like diabetes? What does it take into account all of that?
Yes, it does. I'm going to start at several layers here. It says, don't get diabetes. So
that's the number one advice that a lot of doctors
have. Akin to that is don't have a stroke. But those two things are hard to deal. That's a lifelong struggle. And both of those are pushing your brain chemistry in the wrong direction in terms of Alzheimer's. So the recommendation is, if you're young, you're not diagnosed with diabetes yet, your A1C is at 6.3. Let's do low touch versions to get your A1C down to 5.6, and let's then build a lifestyle that keeps it there for the rest of your life.
So if I'm understanding this correctly, and I'm not the technologist that you are, but
yes, I don't believe you.
You're taking a lot of information that doctors actually should be asking, but we know a lot of doctors don't ask a lot of these questions, and they don't, have a lot of this information.
Because they haven't had guidelines of what the questions are. This is a relatively new field, the extensiveness of it, as you know.
So yes, I do know that, but where is the proof that this is effective and impactful?
Got it. There's a name for this field. And when I started several years ago, there was no name. So it's nice to be in a field that finally has a name, and it's called multi-domain interventions. So the leading group that's doing this has been called the FINGER study, FINGER, out of Finland. Yes. And now, in fact, a global effort. There are FINGER studies around the world going on, and they talk about, given your APOE4 and diet and lifestyle and so on, here's expectations you can have. Christine Yaffe, Y-A-F-F-E, she's at UCSF, and I think she won the Outstanding Alzheimer's Researcher of the Year award this year, understands this process well, has her own track now at the Alzheimer's Association International Conference. There's a group we work with at Weill Cornell in New York. Dr. Richard Isaacson has an Alzheimer's Prevention Center. And so all of these are kind of, well-known, well-documented techniques. And in each of the cases, the amount of improvement and the amount of prevention you can affect are well measured.
Okay, and so
we've done our own, but I'm not here to, here's our own work we published, which is along the same lines.
Okay, so we're getting a lot of questions in now saying, okay, fine, I think you're preaching to some some people who are the converted, they understand this, they've done a lot of research on this. How do people access artificial intelligence? And the biggest question is how expensive is it? You know, we all kind of want to, I mean, some of us want a PET scan, but it's not affordable, right? So how expensive is it to really deploy this type of technology?
So thank you. I am a founder of a company called UMethod Health, so I do have a commercial interest here. So I don't want to.
Yeah, full disclosure, absolutely.
Everything we do, delightfully, years of work is covered by Medicare codes.
Really?
Really. So every aspect of screening, of blood testing, of your doctor getting your report, reviewing it with you, of getting coaching on a regular basis, all of these steps have Medicare reimbursement associated with them. So this has been a delightful take on this new field called multi-domain interventions. The US government says, yes, this is real. That's all new in 2018. So that's how new it is.
Right.
So how do you access this? You access this through your doctor. You certainly, again, we have a company, so it's umethod.com, 7 letters, UMETHOD.com. And so you can, sign up there and we'll point you to an appropriate doctor, but all the interaction is done directly with your physician or neurologist.
So it would be a doctor would have to prescribe this or be using the UMethod technology. It's not like an individual could say, oh, I want a profile.
That's right.
So, and it is that way specifically because of the reimbursement factor?
Because of reimbursement, right? And because of FDA regulations. So, we're not practicing medicine off on our own. We're doing it with respect to your doctor.
Okay, and now we're getting a lot of questions in saying, well, what if you're not so young and you don't have Medicare? Like, what if you're younger than 65 and you don't have Medicare? Then what?
Then you can pay for this individually. It's on the order of hundreds of dollars, not thousands. I was going to say, if you end up with, the biggest challenge is if you end up with a set of expensive supplements, and those themselves can be more expensive than actually the report generation itself.
So tell us a little bit about what type of report we would get, okay?
Oh.
So, actually, let me back up a little bit. Tell us how much information you need from us, and then what type of report you would get. Like, do you need blood test results? Do you need genetic tests? What do you need?
Okay. So we're going to ask for a specific blood test panel. And some of the blood labs here,
like A1C, sugar levels, what does it include?
So I'm presuming those are actually done on a regular basis. So you understand the terms for these. There's comprehensive metabolic panel, there's complete blood cell count. So those in a way only cost $5 to the labs. Those in cholesterol are simple. No, we're going to ask for a longer list. Let's get to my friend here. We start with homocysteine. Homocysteine is a brain toxin, readily treated with vitamin B12, and yet it may be the first thing to address in blood chemistry. We do extensive hormone panel for males and for females. We will look at thyroid extensively. We'll look at vitamin deficiencies. We'll look at zinc and selenium and things like that. So it's a bit longer test than is normally done on a regular annual visit. But every one of those then has its contributors or drivers or follow-on questions. So that's the blood test. So it's about 100 items in a blood test. We'll ask for genetics, and that can come a number of ways. You can do it from 23andMe or Ancestor DNA or Genos, which will give you an entire genome for under $500. Another way to do this is with your doctor, and they can do a cheek swab. And the cheek swab just looks at APOE. And again, knowing APOE for this disease is a good place to start as well. Medication list is the next most important thing. What are you taking? Why? What dosages? Your vital signs. And then we have something called the 35 questions that are the follow-up questions of, or do you snore a lot? Kind of we work down through the list of these things.
So, I think a lot of people are wondering too, we're getting more questions in like, okay, so then the report comes and do you say, oh, look, your homocysteine is XYZ, therefore take more B12, or what types of, what do we see in our results? Do you actually recommend certain supplements?
Yes. So answer to all the above is yes. So the report looks like, the technical term is therapeutics, but there are recommendations related to each of the things that we've seen, and they're prioritized. When I was a kid, they used to say, this is how newspapers are, that says, if you can just read the first 3 inches of an article, that's where the most important thing should be. So, there's recommendations on prescription medications you should be taking. There's prescriptions on recommendations on supplements. There's very extensive information on lifestyle, on diet. I saw you had a nice interview on the MIND diet. So when the physician gets their report about diet, it's about 1.5 pages. When the patient gets their report about diet, it's about 6 or 7 pages, because it says, let's start with the MIND diet, but then here's all the changes we're going to make to it because we've looked at your genetics and understand how you metabolize saturated fats. We know about your gluten sensitivity. We know how you respond to histamines. Don't eat Swiss cheese. Simply because we've looked in genetics. Here's how you respond to coffee. Here's how you respond to exercise. And all of those things then end up in the diet report. And again, I brushed over lifestyle that says we'll talk extensively about sleep, fasting, exercise, and again, given where you are and what you're capable of at that time.
Should people be worried about their results in terms of getting cut off by their insurance? I mean, what if you're like, oh, wow, you have really high risk, and then it's all in a report? I mean, I know people worry about that sometimes with genetics and things. The more we know sometimes doesn't help us, because the more it puts us at risk in terms of insurance.
I hate to say this is beyond my field of expertise.
But I mean, have you heard those concerns from people? Yeah, because we get asked that a lot. No, you haven't. Oddly,
never. So let me do a different one that says we do then ourselves end up with an extensive amount of data.
And what happens to that data?
Well, my terms is it has to be protected better than the NSA. So we actually have no, quite seriously, this is not to be hacked, to be whatever. This is, aggregated, de-identified, but, it's used to look at trending and machine learning and so on in the future.
So if people are to use UMethod Health, how long does it take to get results?
Once their blood has been taken, it's normally just 3 or 4 days back to their physician. If they're starting from, let me get my genetics test, if you do 23andMe, for example, that can take 6 or 9 weeks. And we can then, since the way I describe this, you can get your blood test and your vitals and you can get your first report back. And then 9 weeks later, we can add in the genetics and you can see how it changed and how it responded to what your genetics were. So it can be done in stages, but view it essentially as the same timeline as getting your blood drawn.
Right. Yeah. Okay. So it's fast.
Yeah.
And is it one of the things, as it is with AI, that the more people who use it, the more information you get, the better, the more accurate it is?
That's a great question. I wouldn't have said accurate. I'd say a better understanding. We see more outliers and then spend time with the medical team to understand what this really means. You and I talked earlier about one of the things in a blood draw called HS-CRP. It's related to inflammation. Get that done. Whoever you are at whatever age, get your HS-CRP as part of your next blood panel. You should have a number under 1. A number under 1 says you have very little inflammation. Great, keep it that way. A number above 3 says you have inflammation that may, in fact, be leading you down cardiovascular risk. And without naming any names, we saw someone this week with an HS-CRP of 99. Our target's under 1. So that opened, this was stop, and let's look at the entire vista of what this means. And, there's a population out there that has unbelievable levels of inflammation. And we sat and worked through the entire process of, where do you go? We have to guide someone in this. I know the answer is, oh, well, just go back to your physician, say you have high inflammation, or your rheumatologist. It's like, no, is this COPD? Is this a blood disease? Is this, a reaction to an operation? So there's a fairly long list that then we built into the system because we had never seen that kind of situation before. So your question was, does it make it more accurate? Yeah, maybe for that situation. But mine is it improves the understanding at every level.
So how long has UMethod been taking in data and providing, like, how you're relatively new, are you not?
Well, yeah, we've been doing it commercially since April of 2015. So about 3.5 years at this point.
And what do you know today that you didn't know when you first started?
I actually was prepared for that question.
You've scoped me out well then.
Let me start with a few things. The number one and two I will talk about are kidney disease and medications. Lots of people,
unrelated to Alzheimer's or
unrelated. Let me get there. So the kidney disease was unexpected. When you get your blood drawn and you get it back from the blood lab, there's a couple numbers in there called creatinine and GFR. You may have seen these, and they're in a way talking about your kidney health. But they're wrong. And they're wrong because your kidney health is related to your age and your gender and this creatinine level, but also your body, your height and weight. And since no blood lab ever asks you for your height and weight, they just make a best guess. And they've missed part of a fairly substantial equation that needs to take your body mass into account. Now, your doctor could readily do that, but it's a big, hairy equation.
It takes time.
And so that's one of the, a high percentage of people we see have kidney disease, and the kidney disease needs to be addressed before they take their next pill. I don't want to recommend to them, take this new prescription, take these supplements, because each of those is now a bullet to the kidneys. And so you need to unwrap kidney disease before you proceed in a way with the next step. So that was one discovery. Go ahead.
No, what I really like about this is the fact that what you're hitting on is what so many doctors miss, which is how different systems are interrelated and how that impacts our health, our brain health for that matter, as a whole.
Thank you.
It's and there's more and more research going into this. It's like, just don't look at one thing, look at how everything is interrelated, right? And what can we, if we stop one thing, does it reduce our risk for another thing? And it's a question, and fortunately, I feel like I'm answering to a lot of people because now I've talked to so many scientists and have come to realize that the interrelationships with different systems, whether it be sugar levels, cholesterol, heart brain, gut brain, they're related and they impact one another. And so if there's deficiencies, treat those deficiencies before you run into bigger problems, I think is the moral.
Treat those deficiencies as a system. You can't do them in isolation. So yes. I'm going to go back to a wonderful question you asked. It says, what's the report look like? And I said, well, it starts with prescriptions and then supplements and lifestyle and so on. But it doesn't do that if you have kidney disease. It's, address the kidney disease because I don't want you to take another drug until that situation is addressed. So go ahead.
Yeah. No, go ahead.
A second thing, what was a surprise in a way? 60% of the women we see, the females we see, are depressed.
Interesting.
Yeah, that's a jaw-dropping number. How do we know they're depressed? They tell us. We see they're on an antidepressant. They take a standardized test and you see they're depressed. So there's a number of ways to see, but nonetheless, they're depressed.
And there's been a lot of research into how depression escalates your risk for dementia.
Yes. So like the same old thing here, now I got to unwrap depression before we can proceed with the rest of the things that we need to address that look like other imbalances. So you're hanging in there with me. Thank you for understanding. So let me talk about some of the things that are part of depression. There are drugs that induce depression. So a wonderful article in JAMA this April here said, here's 200 common daily drugs, and here's how they induce depression. So not only was that 100 of those drugs induced depression, the other 100 induced suicide. So again, tell me about your medications, and I see you're depressed. I need to unwrap the medications you're taking that are inducing depression.
So, but that's not based on the artificial intelligence. That's based on other research. Is that right? But you're just able to.
All that research, all of those are rules. So that was one of the first things that says one of the techniques you use. And so all those rules have to be prioritized, and which ones do you do first and second, so on. Now, now hang in here one more thing with me, and then you'll ask me, let me get back, which is now let me wrap genetics and depression together. Okay, that says, first of all, you told me you're depressed, and I've looked at your medications, and I can unwrap that. But just looking at genetics, first of all, I can see the genetics that may be predisposing you to depression, which has a sense of not my fault. It exists, but so the reverse of that occurs that says, oh, you're depressed, but it's not caused by depression, by genetics. And so both of those sides of that argument are worth understanding. Second of all, go ahead.
No, go ahead.
You can look at the genetics for antidepressants. This says, oh, you're on an ADM, you're on the wrong antidepressant medication. You can look at the genetics for the drug, for the depression-inducing drugs. You can look at the genetics for exercise and see, are you even doing the right type of exercise in terms of depression? So all of those things are kind of all wrapped together and yet all become part of the analysis.
Okay, we're running out of time, but I need to ask you this.
Thank you.
If you have a full-blown diagnosis of Alzheimer's and you are, maybe not at such an early stage, can any of this information help you? Because as we know, once the brain starts to degenerate from disease, from a dementia, you can't reverse it. So would any of this information be pertinent for the person who's already been diagnosed and has Alzheimer's disease?
The literalist in me picks on the word any. that says if some of this is related to medications and other comorbidities, those can be unwrapped. And otherwise, the true intention here is start early, prevent as much as you can. The moment you think you are stepping into MCI or past that, that's when to address these things aggressively. And your APOE is your guide in terms of urgency. If you have APOE4, it's urgent, slap in the face that you need to address these things now.
Okay, thank you so much, Dr. Walker. That was really interesting. I think we could go on forever, but for the sake of time, I'm gonna cut us off now. It's really interesting to understand how technology is bringing a lot of these pieces together, and we thank you very much for your work. As you stated, you're a commercial company, but you're getting a lot of data points, and we appreciate the time that you've given us. We certainly look forward to you sharing more insight as it comes in, as I feel like you could be opening the door to a lot of information. So given more and more data that you get. So it's wonderful for you to share this with us. We really appreciate your time.
You're welcome. Thank you. A pleasure.